o también los instamos a poder hacer sus preguntas por el chat para poder hacer la moderación de la debida manera. Igualmente, el doctor Armando Félix nos explicará que podemos activar el closed caption para aquellos que les facilite poder recibir la información en español o en otro idioma. Entiendo que también hay algunos colegas de Brasil y podrían optar por el portugués para poder entender mejor. No quiero extenderme más, solo quiero reiterar mi agradecimiento a la ponencia del doctor Notter y desearles una muy buena jornada a todos. Te cedo el micro, Armando. Adelante.
Muy buenas tardes nuevamente a todos los colegas de Latinoamérica. Para mí es un verdadero honor recibir al doctor Marcus Notter. Ya mencionó algunos parámetros de logística el doctor Gustavo Sarria. Para activar los subtítulos es realmente sencillo aquí a nivel de de esta aplicación. Activan el área de closed caption para que tengan los subtítulos activados. Y bueno, esta sesión va a quedar grabada en YouTube de Alatro para que después la puedan ver. Voy a presentar al doctor Marcus Notter, es especialista en radiooncología, él es radiooncólogo de una larga trayectoria. Inició su residencia en 1984 en el Hospital Cantoral de Arau, en Suiza, tras haber concluido sus estudios de medicina en 1983. Desde entonces se dedicó al desarrollo y establecimiento del servicio de hipertermia. Por lo tanto, estamos con un gran exponente del tema. En 1987 fue el primero en utilizar hipertermia locorregional con un sistema llamado BSD 2000 junto con su mentor y jefe médico, el doctor Wigler, y publicaron sus experiencias clínicas. Hasta el 2005, el doctor Notter trabajó en este servicio, convirtiéndose en el senior en 1988 y posteriormente en un experto líder dentro de la clínica. En el 2005 fue elegido para dirigir el departamento de radiooncología. En 2009 desarrolló el concepto de hipertermia por infrarrojo afiltrado por agua controlada mediante termografía, con el objetivo de mejorar el tratamiento del cáncer de mama localmente recurrente. Desde el junio del 2015 se integró al servicio de radioterapia del Hospital Lindenhof en Berna, Suiza, donde se estableció nuevamente el servicio de hipertermia. En el aspecto de la reirradiación, hipofraccionada dosis baja combina hipertermia que permite alcanzar control local en aproximadamente dos tercios de los casos. Ha participado activamente en diferentes congresos desde 1984 en relación al tema de hipertermia. Además de su experiencia en hipertermia, el doctor Notter es un experto destacado en radioterapia en diversos tumores, especialmente en tumores cutáneos, y también es reconocido consultor en el tratamiento radioterapéutico de enfermedades no malignas. Dr. Notter, good morning, good afternoon, everyone. It's a pleasure to welcome you to this webinar on hyperthermia. And thank you all for joining us. And let's begin. Thank you, doctor.
Hipertermia guiada por termografía.
¿Pueden desactivar los micrófonos, por favor? Go ahead, Dr. Notter.
Okay,
Thank you so much.
thank you very much for the invitation. Gracias por la invitación. No hablo español, but inglés, ma comprendo el español. So I will continue in English. So I would like to present the potential of this new method of thermographic-controlled superficial hyperthermia with infrared. As an introduction, what shall we do when we have an inoperable local recurrence after radiation therapy? This is always very difficult. If we have a small, compact local recurrence, then radiation is possible, maybe with focused high-dose radiation, for instance, fractionated external beam or stereotactic radiation or cyberknife or even BRAF. The question is more difficult when we are confronted with a very extended local recurrence. There, focused high-dose irradiation is no more possible or tolerable. Chemotherapy or immunotherapy in many cases are inefficient or already exhausted, also by the fact that decreased perfusion doesn't no more allow to penetrate the medicament in the previously irradiated tissue. So then arises the question, which local therapy can we at least offer for palliation? And if it's only a local recurrence without any proven distant metastasis, then it is even more important. This solution could be the combination between radiation and hyperthermia, with maybe reduced doses to have a better tolerance and less toxicity. Hyperthermia as a radiosensitizer is already very old as the idea. In the late 70s or 80s, they were developed some theories which times to be time working, and also first clinical attempts were very experimental, are conforming this clinical result. And then comes the question, why is it so unknown, or even not used, or even abandoned? And we have to be honest that up to now there were not so many randomized trials. Also, the fractionation and the RT dosage is not very clear or was not always described very well. We have also Michelin's hyperthermia technique, and also the combining the timing between the two modalities is variable or not always constant. And temperature measurements is sometimes very difficult or even not done. And there is also no clear acceptance of a general thermal concept. Nevertheless, in spite of these problems, the most evidence results are obtained with local recurrent breast cancer. So if we show an example, this is a typical example of a recurrent breast cancer after previous local treatments. First, 96 with breast cancer on the right side, with conservation and radiation therapy. Then almost 12 years later, a second cancer on the left side, also treated again with conservation, with radiation. And then 10 years later, local recurrence on both breasts. So this patient had a bilateral mastectomy, and it was offered to her an adjuvant chemotherapy. And now what happened is shocking. You see, after X local chemotherapies and general chemotherapies, even the most used medicaments, we have this disaster, a non-controlled local recurrence. And the question is, can we really avoid? So locally recurrent breast cancer limits in a horrible way the quality of life of such patients. It's a decaying tumor with odor, with ulceration, special wound care, social isolation. And when I present such patients, then I always hear from my radiation oncology colleagues that this is a very rare event or they don't see such patients. That means also that these patients are disappearing completely, are no more longer listed in any statistic, and almost nobody knows about them. And the question is, can we estimate how many women are suffering from such a disaster? If we go to the statistics, in 2020, about 2.3 million women worldwide were diagnosed with breast cancer, and about 685,000 died. Local regional control and survival has been improved due to the advances in screening, diagnostic imaging, and better systemic treatment as well. However, the 5-year local recurrence rate is about 2.5 to 3.5%. Despite this relatively low rate of local failure, the absolute number of local recurrent breast cancer is still increasing the growth of the absolute number of breast cancer patients and breast conserving treatments. And local treatment of local recurrence is done by salvage mastectomy after initial breast conserving therapy or a local excision after initial mastectomy. If we have high-risk local recurrent breast cancer patients, means the tumor size was very large, T2 to T4, or lymph node involvement, or there was no radicality of the resection, or blood vessel infiltration or lymphangiosis, and negative hormonal receptors, or all of them together, there is an indication for a postoperative radiation or re-irradiation after surgery in order to improve local regional control and survival. In case of re-irradiation, the total radiation dose are sometimes very limited, and therefore superficial hyperthermia can be added to improve these results. In the Netherlands, routinely combined postoperative superficial hyperthermia and radiation is a standard. And in single-arm retrospective studies, three-year local regional control ranges from about 70%. And the meta-analysis of previously irradiated patients showed again a very high complete response in unresectable local recurrence compared to only 40% after radiation alone. If we go to the literatures, we see there are 3 randomized trials, one from the ESHO from Vernon in the late 1960s, a second one from the United States by Jones, and Overgaard showed even a reanalysis of the ESHO trial. All of these 3 randomized trials could show a clear benefit of combining radiation with hyperthermia in locally advanced or recurrent breast cancer. And we have also some non-randomized trials or retrospective analysis which show about the same high remission rate. If we go to the requirements of superficial hyperthermia, we should provide a heat range about 0 to 3 or 4 centimeters with a temperature increase up to 40 to 43 degrees Celsius. We should provide a certain temperature control on the surface or even intratumorally. We should monitor the temperature distribution to avoid overheating or side effects. And of course, we should also provide that we can cover the whole manifestation. And what about ulcerating tumors? It's not so easy sometimes. And we have sometimes also to think about limitation due to anatomy or body configuration. And metallic implants or reconstructed tissue can be an issue as well. And of course, the patient should also be comfortable. The most used superficial hyperthermia techniques are by microwaves or infrared.
Los 10 camas, todos son los mismos, a menos que cambie el mes. Y el mes trae 28, pues los 10 camas.
Sorry, doctor Norton. Quien tenga abierto su micrófono, ¿puede apagarlo, por favor?
Okay, sorry, I didn't know what happened. If we go to technical requirements as well, if we have a relatively small local recurrence,
Señor,
the
ve a
current
ocuparte de tus cosas.
microhyperthermia can cover it. If we have a microscopic lesion of a mastectomy, for instance, then a small field is still possible. But if we want to irradiate and retreat the whole chest wall, then it can be already limited. And if we have such an extended local recurrence, then with microwave techniques, we are out of any possibilities to retreat that. If we have a large region like this,
José, estoy en la conferencia.
Disculpen, ¿pueden apagar
Lo que
su
pasa es
audio?
que cada rato me saca.
pero no puede tener su micrófono abierto. ¿Lo puede cerrar, por favor?
Okay.
Bueno, bueno, yo tengo las 3:30 ya, pero como estoy en la conferencia, estoy esperando de aprovechar y está en la conferencia.
Por favor, apaguen su micro.
Okay, thank you. Then what we tried was to apply a certain patchwork technique. That means we can provide a large radiation field. This is technically no problem. And then we added just several applicators to cover such large lesions. But of course, it is not so easy to do. This was in the late 80s when we do that. And of course, we have to think to improve the hyperthermia technique. That was the reason that I was engaged in the idea to use infrared hyperthermia. If we have again this example, then we can use an infrared source with some filters, and then we can use the reflected radiation by thermography. And if we combine it with a computer, then we have a relatively simple system which can provide a thermographic controlled hyperthermia. The advantage of infrared with water filter is that it's similar to sun spectrums, which is relatively well tolerated. And we can achieve a greater heat deposition in about 2 centimeters, still 39 to 40 degrees Celsius. Also, pain is heat reduced, and we have even a better compliance. And this advantage gives us the possibilities to reach about 2 centimeters with infrared hyperthermia. Compared to microwave, it's less, but it's similar for the first 2 centimeters, and this is important for the clinical application. The machine looks like this. We have two independently steered applicators, which are also controlled by a thermography and safety system. Everything is controlled by a computer. And you see on the left side an example of a patient treated two applicators. Another advantage of this system is that we can use thermography to control the whole surface and manage the hyperthermia in the field. We can also repeat it continuously and get some curves that are known for every system, and can also, like this, analyze the temperature distribution as well. And another advantage of the system is that we can treat different treatment situations. For instance, a locally very advanced breast cancer, even with two applicators, side position or sitting position. So we are really flexible from the clinical point of view. When we are thinking about treatment schedules, we can say it's principally the same as already in established other treatment schedules for superficial hyperthermia. The mostly used schedule is 10 to 12 times 3 gray in the Netherlands. Previously, when there's no previous radiation, we can do any fractionation, of course. When we are using it for melanoma, sometimes for small lesion, it's 3 times 9 gray, or for large lesions, 5 times 6 gray twice.
Por favor, pueden desactivar su micrófono.
And when we have heavily radiated radiation regions, then we have to think about low dose radiation. And now it comes the timing of this, or the combining of these both two treatment modalities. And timing, that means how we are applying hyperthermia radiation is very controversially discussed. But this is also different, dependent on different pathways of radiosensitization. We have to think about reoxygenation, which is a very potent radio sensitizers, which starts already at 39 degrees Celsius. We can think about DNA repair inhibition, which is achieved about temperature in 41 degrees Celsius, which is also lasting longer. And we have even direct destruction or other mechanisms which should be considered. The most frequently used schedule is primary radiation and then hyperthermia within less or more 1 hour. Reason is mostly logistic problems. But if we have only very limited radiation doses, then we have to try to apply as close as possible both treatment modalities. That means a near simultaneous approach. And to achieve the maximal effect, then I start primarily with hyperthermia, and then I combine radiation within some minutes. And this is very, very close and very almost simultaneous. The purpose can be illustrated in this example. We have a lady who had already former radiation treatment, 91 chest wall and lymph node irradiation with even cobalt at that time. Then a second radiation on the left supraclavicular fossa with 50 gray, and the new radiation due to recurrence 2015. So we see it's almost no more possible to combine a good radiation therapy in this local recurrence. And the solution is that we are starting this large field via hyperthermia with infrared, and then we are giving a large electron field within some minutes. So less than 5 minutes, and this is only 4 gray per fraction. The schedule looks like this, that I give 5 hyperthermias once per week with the aim to achieve on the surface 42 to 43 degrees Celsius for about 45 to 60 minutes, and immediately after the radiation, 4 gray. Also only once per week, preferably with electrons, but you can also use photons. And to achieve the skin temperature up to 43 degrees Celsius, or to maintain the skin temperature, then I add a bolus which is preheated. And the patient is transferred to the LINAC with a thermal shield or a blanket like this. This looks like this practically. We have a patient with a superficial hyperthermia treatment, about 45 to 60 minutes. After that time, the team on the linear accelerator is informed and charges the patient data. That means we need a coordination between the two teams, LINAC and hyperthermia, which can be done in the same institution, I think, very easily. The patient is wrapped and accompanied directly to the LINAC treatment room. So we have to try to be close as possible in both rooms. And then you just are doing a speedy positioning with electrons very fast, but also with photon fields. It can be done rather short. Verification is necessary, of course. And then we are applying the preheated bolus for both electron or photon fields. And within 1.5 minutes, we can start the radiation. So we are very, very fast. With this schedule, I analyzed 170 patients with a macroscopic disease and another 31 patients with a microscopic disease. And you see what we have achieved. Depending from the tumor extension, that means small tumors to large tumors, which are even surrounding the patient. In French, we call it cancer aquinas. We have seen that we could achieve overall a complete remission about 43%, depending on the extension, a very, very high remission rate, and also partial remission has been achieved in more than half of the patients. At an overall response, about 95%. That's very impressive. But it is even more important for the patient that this complete remission can also be maintained. And this table shows you about the 73 patients with the complete remissions, what happened with them. And we could see that about 2/3 or even 70% remained locally controlled. And only a few had really relapse again. Not in the extended tumors. These, of course, are very difficult to control for their lifetimes. But also those with a partial remission still had, in half of the situations, a local progressive-free time or survival, about half of the percent. Side effects with this very low radiation schedule is also very low. So more than half of the patients didn't have any side effects, Those who had some had slight radiodermatitis with hyperpigmentation, and we had only one patient with these 201 applications with a small blistering. So it was also very well controlled as this. And chronic side effects were observed also only in 1/3 of the, which means hyperpigmentation, and in some heavily predation patient new telangiectasia. The survival, of course, is dependent on the extension of the local recurrence. Those with microscopic disease or small recurrence have a rather good survival, also knowing that some of these patients have, of course, already distant metastasis. Those who didn't any metastasis have a clear advantage. That means that a local recurrent breast cancer is not lost. It's not always a palliative situation. If we achieve a local control, the patient can really profit from that. I show you some examples here before and after the treatment. Only some weeks after that, we have this almost complete remission of a very large local recurrence. And even the portal CAT system was no problem. This is another example with a partial remission 2 months after the treatment of this lady. And this is another patient also with a very distinct regression. Also, it was not a complete remission, of course. And the last example is a triple negative cancer. And also in this situation, some weeks again, after the combined treatment, we have a very, very good local remission. Patients who are presenting a large local recurrence have some limitations. They go out of house only with their care of wound bandages and things like this. So when they are in your consultation, they always bring a bag with them with all the material they need to cover and to care. And the question is, this is very, very difficult for this patient, and the change of wound bandages and disinfection is also a lot of work, as we have to do when we are treating them in our ambulatory. And the question is how much time they are spending for the daily life, special bandages to avoid infection, or if you have a decaying tumor or odor, are they isolated? Do we need some special shower heads? Can they still go out? What are the economic impacts for this? The psychological situation, social contacts, and things like this. So it's very, very limiting for this patient. We analyzed the need of wound care or bandages of 70 patients who had an ulcerating tumor. And you see that in 93% of the patients, they didn't need any bandages or had a really reduced care of that. And if I show you an example, we have a patient with an ulcerating tumor. At the end, it was already very distinct regression, but still she needed some bandages. But if she came up in the follow-up 1 year later, we see that it's very dry and there is no any bandages necessary as well. So a very, very good palliative effect for this patient. And the need of analgesics is again also very impressive what we could achieve from those who had a need of analgesics. In 80%, they could reduce or abandon completely the need of analgesics. The technique allows us also to treat other very difficult regions to treat. For instance, in the head and neck regions, supraclavicular or chest walls, as I showed before, but also perineal or foot and tooth. So the Vera hyperthermia technique has in this sometimes very difficult cases or situations to treat some advantage as well. If we go to the head and neck cancer, we have in the literature already very good results from different studies. Overall, they were positive, but we have to admit there were only small numbers and the small patient recruitment. And also, the treatment of head and neck cancer is not so easy to do. So they have different techniques and radiation doses as well. And if we go in such a situation with a very extended head and neck cancer, either skin or head and neck cancer from the throat, we have different diameters, cooling of vessels, cooling through air breathing, and the temperature measurement is not easy as well. And the microwave hyperthermia has the advantage that they can achieve deeper in the body, but we have cooling effects of the bolus using to cool the surface. We have also sometimes limitation in application, and hyperthermia with VIRA, with infrared, is contact free. We can treat large surfaces. We are maybe more limited in the penetration, but we have a better patient comfort as well. I show you a patient with unknown primary in the head and neck region before and 7 weeks after. And this is another example of a patient with a recurrent laryngeal cancer who had already different radiation and resections and chemotherapy, and then she had a local recurrence just around the tracheostoma, which is almost impossible to treat with microwave hyperthermia, but with contactless infrared we could achieve a distinct regression of this tumor in tracheostoma. And this is the corresponding PET-CT, and also here you see a reduced activity 8 weeks after the application of this re-radiation with hyperthermia. This is a man with a locally recurrent squamous cell carcinoma of the scalp. And you see also here with this reduced radiation dose at 5 times 4 day, once per week, a very, very good remission. Or this lady who has already a previous radiation on a skin tumor on the nose. You see also how we can shield and conform infrared field with some infrared shielding. You see also the results 5 weeks after radiation. We have also such extended local advanced basal cell carcinoma sometimes. This was a very old lady, 87-year-old, and you see 2 years after the treatment, she still had a very, very good local situation. Or a man with a Merkel cell carcinoma, heavily pre-irradiated on both sides. He was under immunochemotherapy with amemulab and had a very rapid progression. You see the corresponding PET-CT on the right side. And this is the example after radiation with 4 times 4 day, once per week with hyperthermia. So a distinct regression and improvement of quality of life. Another patient with a Merkel cell carcinoma on his right leg. You see also before the nodules, and only after 3 applications already distinct regression. So also here, he could no more tolerate any chemotherapy due to diabetes and renal insufficiency. And this is a recurrent melanoma of an old patient who had already been formerly irradiated. And you see 3 weeks after, a very good radiation, and the complete remission lasts even 1 year after. Or this lady with a amelanotic melanoma on the foot before and after treatment. So she had no amputation. And this is another example of a recurrent melanoma before and after treatment. So this schedule is very well tolerated and achieves very, very good remission. Or the question about hemangiosarcoma after breast conservative therapy, which occurs more and more. Also, it's fortunately very seldom. You see this lady after the 4th recurrence of a hemangiosarcoma. She had already amputation on both sizes and several surgical removements. And you see 6 months after the radiation with hyperthermia of a radiation-induced tumor as a complete remission, which lasts even 20 months later. And this hemangiosarcoma can be sometimes extremely aggressive. You see the preoperative sedation of a patient with a breast-conserving therapy. He had this very extended hemangiosarcoma, and the plastic surgery did some biopsies around to be sure that they are in normal tissue. She had a large mastectomy, but within some weeks, already around the mastectomy scar, a first recurrence verified by biopsy. This was the situation when she was referred to my department. And you see now 4 years after radiation with 5 times 4K only once per week and with severe hyperthermia still locally controlled. This is another example of a patient with a lung cancer who had a supraclavicular spread with pain and nerve infiltration and also skin involvement. She was referred for a new radiation with hypothermia, and she had a very, very good local response, not complete response, but still. And then she unfortunately developed skin metastasis. So the medical oncologist started with a new chemotherapy, and the patient had a severe toxic reaction under this. She survived, fortunately, but of course it was a disaster for her. And you see now the situation before and after, 2 weeks after, 5 hyperthermia with 5 times 4 gray and hyperthermia. The medical oncologists were very impressed by these results, and now they refer regularly patients to me because they have never seen a such good response before. So, in summary, we can use this technique for different tumor localization, mainly, of course, for locally recurrent breast cancer, but also for local advanced primary breast cancer is a possibilities, radiation-associated angiosarcoma, or non-melanoma skin cancer or melanoma skin cancer. We have some rare case reports about Merkel cell carcinoma or primary angiosarcoma of the skin. We have some studies and case reports about head and neck cancer, and in England by Anthony Kong on the King's Hospital in London, he plans to do a study about that. We have also reports from skin metastasis and recurrent vulvar cancer patients. So as a conclusion, infrared hypothermia controlled by thermography and the low dose radiation is a very effective palliation report. It can achieve higher emission rates, and these emissions can even maintain for lifetime in a lot of patients. Outpatient basis possible in an ambulatory. We have a very low toxicity, can improve quality of life, and can even be repeated in some special situations. And the extreme low dose radiation, there it's very important that you're timing the hyperthermia and radiation therapy very consequently. That means as close as possible. And if you are doing that, the results are not inferior compared to classical radiation doses combined with microwave hyperthermia. And there is definitely a huge potential to help patients with this relatively well-tolerated, effective, and easy way, in addition with rather low economic implications compared to other cancer care. As, for instance, in local breast cancer, in local advanced breast cancer, and all the other tumor situations as I presented before. And the thermographic controlled infrared hyperthermia opens a perspective for many local recurrence in different localization. And I think, as already established in Switzerland, superficial hyperthermia and radiation should be accepted also in other countries as a standard in specific situations. We have some run clinical studies, like in the University of Freiburg in Germany, with a histological analysis of hyperthermia and radiation. We have in Switzerland now a randomized trial which is running about skin cancer. And we have in the King's Hospital in London the attempt to start a ThermoRad study really to assess the real world of thermotherapy using infrared hyperthermia in addition of different tumor situations and compare it to care. And why is in hyperthermia booming hyperthermia in Switzerland? And this starts some years ago, almost 9 years. We had only 2 institutions, my former hospital in Aarau and the clinic I'm now running in Bern. And then we had the foundation of a Swiss hyperthermia network with the aim to get a collaboration with the Federal Office of Health in Switzerland and also include the same time insurance companies. And we could show with some important studies, meta-analysis or single randomized phase 2 trials or speed trials, that there is an indication for combining hyperthermia with radiation. And finally, the Federal Office of Health accepted this combination in selected tumor situations with the condition that we are presenting it at a tumor board, which is now done weekly in Switzerland, and that we are also providing quality assurance protocols and measurements. This is very important. And the result is now that we have in Switzerland many clinics which are using radiation and hyperthermia. So it's really booming. So I thank you very much for your attention, and I'm open, of course, for questions.
Dr. Notter, thank you very much for your excellent presentation. Definitivamente, estos casos de recurrencia, especialmente en cáncer de mama, son casos clínicos reto, son casos clínicos
Mantenimiento
de
y
cierta manera
habilitación de sensor de
muy
campo terapéutico.
trágicos
Me
y
dijeron que para esta hora ya estaba para recoger, pero no me han llamado.
doctor Sarria, entonces mi pregunta es si me entiende, doctor Notter.
Sí.
Ok, eh, ¿cómo coordinar la dosimetría o la planificación de una paciente previamente radiada y que vamos a combinar ahora radioterapia externa con fotones o electrones e hipertermia? ¿Cómo predice usted o cómo hace una suma de dosis de una paciente que se le dio un esquema de 40 en 15 o de 50 en 25 para que pueda ser segura? Esa es mi pregunta.
It's a very good question. Thank you very much. And of course, it's not so easy. We need to combine the thermal radiation in our planification system with the actually planned radiation. And this is already a very heavy work for our planning dosimetrists and physicists. The biological consequences of this
Markus,
combining.
jetzt ist wieder sehr laut. Sehr großes Echo. Hast du was geändert?
Okay, geh mal schnell weg. Is it better?
Yes, it's okay.
Okay, sorry. So the combining of the two treatment and the calculating the effective biological dose is not so easy. We have to think about the past time between the 4 radiation and the actual radiation. More time we have between the two applications, better is the new toleration. Sometimes the tumor has already destroyed important tissue like nerves, that then it's less an issue that we are giving a second dose. And my approach was with this very low dose radiation, we have almost no toxicities when you are doing it with hyperthermia. But it's not so easy to do in any situation. I agree completely.
Ok, excelente. No sé si en el chat haya más preguntas en
Yo
respecto
tengo
a
una,
esto.
tengo
Sí,
una
adelante.
pregunta para el profesor Notter.
Sí.
Bien, it's about of the thermal conductivity and relation to adipose tissue reduction regarding to the aging. In the context, how does the age-related reduction of subcutaneous adipose tissue and the hypodermis, right? Alter the interpretation of localized hotspots in the elderly patients. How you interpret this?
Also, very good question and not so easy to answer. One advantage is that we can observe the surface already with the thermography. So we can see hotspots on the skin. But of course, if we have subcutaneous tissue, which is less perfused, it's a danger that under the skin we have hotspots we cannot really see. So we once try to ask patient what she feels, if she has still any sensation. And otherwise, we have indirect information about the thermography that it could be a certain hotspot. On the other side, we can say it's an advantage when we have a less perfused tissue that we can achieve the heat there better. And when it's infiltrated by tumor, then of course we can achieve here hyperthermia. So I think sometimes we have to balance between the two difficulties. One to avoid heating, on the other side to achieve the heating and to treat the tumor. But I admit that in this heavily pre-radiated patient and sometimes also with some surgical scars, which are very difficult to handle, it's not always so easy to get the best effect.
I have another question related the clinical characteristics, like the time between one scheme of radiotherapy, el intervalo entre un esquema de radioterapia previo, la extensión cutánea, qué superficie máxima podemos tratar y la biología del tumor para que sea una paciente ideal para darle hipertermia y reirradiarla.
Let's say, smaller the recurrence, better the situation in any way. Unfortunately, these recurrent breast cancers are sometimes presenting a very extended tumor, like the cancer acquiras around the thoracic wall, so it's not so easy to do. I do not exclude any patients. I try to help them because even with large fields, we can achieve very good remissions. Also, it's not a complete one.
Perdón, Alejandro Santini, ¿puedes? O no sé quién sea, perdón. Gracias. Adelante, doctor. We can continue, Dr. Notter. Sorry.
Yes. So, but as I tried, I do not exclude patients with very, very extended. I try to do it. Sometimes I have to start with one point of the body and I add a secondary on another part of the recurrence. Of course, we have then the danger to overlapping, and this is fortunately tolerated with the schedule as I presented. 4 gray only once per week, a rather low dose. Biological, we cannot really calculate what that means. 5 times 4 gray only once per week. Completely different to a normal fractionation every day or twice or 3 times per week. So there is no clear biological model. But fortunately, from my clinical experience, we can say this is very well tolerated and we have up to now never seen any severe side effects. Also, we have some on the
Gustavo, no sé si tengas alguna otra pregunta.
No, yo solamente quería agradecer la presencia y la experiencia que nos ha compartido el profesor Notter. Creo que es una herramienta desde el punto de vista radiobiológico muy potente. He tenido experiencias hace varios años ya, pero no ha sido consistente por la falta de disponibilidad en nuestro medio. Esto podría servir para pensar de qué formas podríamos tener más oportunidades de contar con estas herramientas de hipertermia, que de hecho tienen un rol fundamental. Entiendo yo que en algunos tumores inmunológicamente corrientes. Puede ser importante coger esa experiencia y tratar de ver cuáles son las opciones para contar con ello, ¿no? Pero no quiero dejar de agradecer finalmente el aporte del profesor Notter y su contribución con el conocimiento para nosotros. Creo que ahí yo cerraría esta actividad.
Yo quisiera preguntarle al doctor Notter si en la práctica o en la educación de los residentes de radioterapia en los Países Bajos ya tienen una materia como tal de hipertermia, porque veo que hay bastantes centros de hipertermia donde situaciones especiales ya se usa de manera rutinaria en casos recurrentes la combinación de radiación externa y esta modalidad de tratamiento. Ya es una rutina en este sentido, porque aquí en Latinoamérica no tenemos infraestructura y quizás sea el tiempo de cambiar la conducta y poder implementar esta técnica acá.
At least I would try to help if you have such questions to implement this technique as well in Mexico or in the other Latin American countries, of course.
Okay. For me is all the question. Solamente agradecerle, doctor, su presencia aquí con nosotros por este gran mensaje, a todos los que nos permitieron organizar este gran evento y queda abierto, yo creo que este campo para que nosotros en Latinoamérica pensemos que la hipertermia es una buena opción de tratamiento para las pacientes que recurren y que no solo se aplique en mama, sino en otros escenarios. No sé si quiera darnos un mensaje final, doctor Notter.
Sorry, I didn't understand. What did?
Maybe if you can send us take a home a message for all the
Okay.
audience. Yeah.
For very well. I would like to. So I think hyperthermia with radiation has such an important and very high potential to achieve better results that I would recommend really to invest in this technique. I think it's the most cheapest radiation sensitivity method we know compared to any other medicaments. So I think it's a very interesting combination. And we have to think also that in future we can even combine it with chemotherapy or with immunotherapy. So I think it opens a new field to treat in a more better way our patients.
Okay. Pues muchísimas gracias. Thank you very much, Dr. Notter, for this excellent presentation. Y con esto pues damos por terminada la sesión. Invitarlos al próximo webinar en mayo y recordarles respecto a nuestro próximo evento magno, que es el Congreso de Alatro en Montevideo en noviembre. No sé, Gustavo, ¿quieres agregar algo al respecto?
Gracias, gracias Armando. Sí, reiterar nuestro agradecimiento al ponente, invitarlos, como dices tú, a nuestro evento de mayo, pero sobre todo, por favor, agenden la reunión de la radioterapia latinoamericana que será, como ya sabemos, el 5, 6 y 7 de noviembre en la ciudad de Montevideo. Oportunidad para presentar pósters, papers. Si hay algún tema que quisieran resaltar, comuníquenlos. Tenemos abierto el WhatsApp. Estamos en redes para que nos puedan comunicar. El programa está en elaboración ya y estamos consiguiendo ya la presencia importante de la industria para los auspicios y también la presencia de sociedades de radioterapia de Latinoamérica que ya han confirmado su participación. Es el momento de tal vez agendar y tenerlos presentes en esta reunión que considero que es importante para nuestra radioterapia en América Latina. Están todos invitados como se podrá entender.
Ok.
Muchas gracias a todos.
Thank you, doctor Notter.
Thank
Muchas
you.
gracias a todos los participantes y
Sí hay una
excelente
pregunta
presentación.
más
Muchas gracias.
en el chat.
Muchas
Hay una
gracias. And if you have questions, you can always contact us.
Ok, muchas gracias. Hasta luego.
De nada, gracias.
Hasta luego y
Gracias.
gracias.
Hola, buenas noches o buenos días.
Buenas noches y buenas tardes.
Gracias.
Saludos. Bye.
Muy amable.